Okay, thank you, Peter. Thank you, Headway, and thank you, Ali, Jane, some of the other people I've been in touch with in the run-up to this conference. It's a real pleasure to be here, to be speaking on this topic. Without further ado, I'll take us through the overview that I'd like to speak about today. I'm going to describe a new approach that myself and colleagues have been working on for a few years now. It's very much work in progress, so any feedback questions would be much appreciated and most welcome. Part of what I'll do today is look at some of the research literature in the area. I'll try and keep that fairly succinct, but to pull out the key themes, the main findings that have led us to think laterally about working in this area. In particular, I'll be critiquing some of the traditional approaches and looking for, well, traditional approaches which sometimes have simplified things, I think, a little bit too much. And then I'll describe the new approach that that is emerging, and say a little bit more about that, what some of our research is saying, and also what it might look in practice, which is, after all, where it's felt by yourselves particularly. For the purposes of this talk, I'll use the term relatives, family members, and so on. But it could, a lot of what I discuss could be equally applied to any member of the social network around a person with a head injury. Okay, the traditional approaches, and this is a big generalization, obviously, but have tended to focus inwards on the brain to try and reduce mind, thoughts, cognition to isolated brains. So it's an inward-looking approach. Obviously, there's very good reasons for that, but do we need if you like, a two-pronged approach as well? Traditional discourses can be very deterministic, and this is really now reinforced in the era of scans, where we get very detailed pictures of people's brains, and relationships are rarely thought about within this traditional discourse, or when they are thought about, are seen as, if you like, an end product from a linear sequence that moves from the brain to its impact on the survivor to the closest relative or main carer. And it's full of lots of jargon. Some of the terms are listed there. And relatives are often seen as people who are burdened or strained or who are in denial, and we don't always use joined up thinking. We don't always think about how much of the relatives' processes are connected to the survivor's processes. A lot of this research, like all medical research, aspires is ambitious, and the aspiration really is to produce what we call randomized controlled trials. And within rehabilitation, there was the beginnings of a critique of this and what this could give us, beginning with the NSF in 2005, where I've taken this quote. I'll just let people study it, but I'll also read it out aloud in a moment. Randomized controlled trials and other quantitative methodologies are not always necessarily best suited to research questions involving long-term outcomes, which is the nature of the work Headway does, varied populations with complex needs, and assessment of impact on quality of life rather than cure. Longitudinal studies, that means studies that are carried out over, tens of years maybe, and other well-conducted interview-based research, qualitative research, are therefore equally likely to be appropriate methods to evaluate the interventions that the NSF was recommending. And this sums it up quite well as well, I believe. This is written by Derek Wade, he works in Oxford. And this was in one of his editorials in a leading journal, and it says, well, when the action or a medical intervention is a delivery of a specific drug, and a good prime example of this would be, say, insulin for somebody who's diabetic. When the intervention is that specific, we can completely isolate it, control it, and research it, and you compare what giving the drug, what the effect of giving the drug to not giving the drug, not giving the drug. So it's just a simple comparison, and the comparison is really just an intervention that lacks that ingredient, that drug. But for complex, multifactorial interventions. Multifactorial is just like, when there's lots of different professions involved, lots of different aspects to the approach, such as surgery or rehabilitation. A lot of this research that we aspire to is not relevant. Establishing control in those kind of trials is much more difficult. In rehabilitation, it's much more difficult because it's so complex. And not least because the intervention is rarely a specific item, a specific drug. If it was that simple, we probably wouldn't be sitting here now. So this kind of, if you like, wider critique and wider context made myself and a lot of colleagues question what the research was telling us. And we know that there are layers of complexity from our observations we all make about brain injury, about head injury, that need to be accounted for by a new approach if it is to be relevant. For example, when memory impairment presents when a person is challenged or angry. When memory retrieval improves in the context of a more positive conversation. When impairments improve when a person is in their own environment. When survivors can problem solve when presented with complex problems by people they know but cannot solve simple problems presented by people they don't know. What's that all about? And when behavior or communication problems that are present with some family members are just not there with others. So that's, if you like, the challenge, and the new, what I call relational approach. It's a family approach really, and a social approach. That's what we're taking on, if you like. We're taking on that challenge, and our if you like starting point is to perceive and conceive of brains as connected to other brains. Brains are always in communication with other brains. Okay, so it's an outward looking approach. Yes, there's an injury, and we need to understand that, but we also need to understand what's going on outside. Okay. What I'd like to do is just chart quickly what some of the research has found, And I say dominant research, so some of the traditional research, but also some of the research which has included family members. And initially, family members were included in trials and research to offer another perspective on what the injury was, you know, like a second opinion. So that was how family members began to get included in research. We then saw, if you like, the same kinds of research questions that were being asked of survivors, being asked of family members as well. What causes distress? What causes distress in survivors? What causes distress in relatives and family members? Lots of psychological research out there exists on, you know, on that topic, on that nature. And then then there was, if you like, another wave of research that began to look at, if you like, quality of life questions that are referred to in the NSF. And this is where things began to get a bit more family focused. Okay? And there was a whole raft of studies coming out in the 90s that looked at family needs. So beginning to look at the family as a whole, as a unit, using mainly questionnaires. For example, the family needs questionnaire. A lot of this research was conducted in America, but also in Europe. And there were also studies that looked at rehabilitation outcomes. And these studies also had something to say about family life and family influences. You had to sometimes read the small print, but it was there, and it was a voice that was getting stronger and stronger. And I'll say a little bit about why that might be in a moment. Some of the main findings were that, well, actually relatives often had the most accurate picture of what was going on in the home, or what was going on with their injured relative. So we need to include them, we need to speak to them, because they often know what's going on, even more so than staff. Another finding that was coming out of the, if you like, the survivor literature, and then was mirrored, if you like, in the relative literature, was that, well, actually, when we look at what predicts distress, it's not always what we call severity. And furthermore, there are, if we look for them, sometimes positive aspects of injury and caregiving. For people who led very busy lives, a head injury throws the family together, you know, in a kind of norming and storming way, and although there can be a lot of distress, family members often see more of each other. And there's also a whole literature coming out that is looking at, if you like, the positive aspects of any trauma, you know, because it sometimes forces people to reevaluate their priorities, their way of life, and so on and so forth, what they call post-traumatic growth. The family needs literature was finding that, well, relatives have the same need to make sense of the injury, share the same loss of sexual intimacy often, and have the same experience of social isolation. They need Headway's attention, maybe even more so than the survivor. And relatives often wish to be involved in rehabilitation, are ready to give up a certain aspect of their life. They've reevaluated their priorities, and they're ready to give up a certain aspect of their life perhaps. And the literature also gives back into the fact that the level of psychosocial support given to the, I've written patient, apologies, survivor or family impacts on rehabilitation outcome. So maybe things are a little bit more complex than some of the literature initially had us believe. From a family therapy perspective, we often talk in terms of symmetric and complementary patterns in family life. For example, you know, there's a whole evidence there as well, and an emerging literature about depression in the survivor or relative is mirrored in the other. So there's lots of studies now that find that if we find depression in the survivor, we're more likely to find depression in the relative or caregiver. Also, initially this came out of the child brain injury literature, but if there are behavioral problems, particularly in children, or executive problems, that's the ability to manage yourself, essentially, and organize yourself to have a strategy when you get up in the morning. Those issues are particularly lead to poor coping in the family. So maybe not severity, but actually the type of problem that people, that the family is faced with. And there's, if you like, a sense that the injury is shared, and that's borne out in the new types of studies that are being done. And researchers also speak of, if you like, the ambiguous loss that may reflect quite a profound change in a relationship. We also have studies that have found that, if you like, rehabilitation outcomes can be predicted on the basis of how well a family is working together, which is very, very interesting and very, very relevant, I think, because we can intervene into the family and support the family, whereas the internal injury with that, it may be more difficult. So family intervention can be helpful and can be successful for improving rehabilitation outcomes. This is now coming out of new studies. So it gives us a rationale for thinking broader and including relatives and families in interventions and supporting them, which is, after all, one of the NSF conditions and aspirations. And we have some very specific studies that have applied cognitive behavioural therapy to the family in New Zealand, who've developed curriculums for relatives to help them understand what is going on. And we've got beginnings of, if you like, systemic family therapy approaches being trialled here in the UK that include sibling work, that include bringing whole families together for support groups, and private work. Some people doing very successful private work as well. In terms of charting, if you like, the next 10 years for research in this area, what I call circularity, if you like, the more complex way in which an injury is shared and also resolved, perhaps. Evidence for that is becoming clearer, and it needs to be built into research. Inconsistency, variability, flexibility, complexity. This is the reality of a head injury, and we can see it in the research literature as well, in the rehabilitation research, and this can be equally informative and enlightening. We shouldn't dismiss it. It's not necessarily just bad research. It may be pointing out that We need more complex interventions. We need to think broader. Okay. I'm not sure about time, but I'd like to take the second half of this talk just to describe some of the initiatives we've been doing when it comes to applying some of these ideas and some of these research studies to clinical aspects of care. First off, a good colleague of mine, Giles, Yeates, who I've collaborated with very closely on this, talked about how there's a, if you like, the skull seduction of traditional approaches, and if you like, how that manifests in the clinic is that relatives are seen separately on occasions. Survivors, obviously, have a lot of care focused on them. But what about bringing them together? Maybe that could be a way of actually practicing what we preach and what we're finding if we look again at the research. We also need to be careful, I think, of pretending we're brain injury experts and perpetuating this focus on a damaged brain as you know, as the location of all problems, and where, you know, only there can recovery take place. It limits our options for change. And there's a whole richness of, if you like, resources that a family brings to a head injury situation, and we need to maximize and make use of those. So if I'm, if you like, looking ahead now, armed with what I know, we need to broaden, if you like, the professional power base. Talk about these issues with the research. Talk about what families need, and collaborate at a professional level. Fortunately, there's lots of people, lots of professionals out there who are interested in these ideas. Believe you me, I have nearly 200 members of a network I've been developing, most of which are in the UK. About 160 of those are in the UK. We need to think about how we engage and intervene with families. Maybe we need to kind of apply therapy developments to brain injury that we might otherwise dismiss. Narrative therapy is one such approach. It's a very positive family therapy approach. So we've looked to, if you like, advertise our interest in this, and there's lots of professionals out there who've been interested, who've come to our workshops, who've supported me in my fellowship. Peter knows quite a lot about that fellowship, but this was the one at the Royal Hospital of Neuro-disability. And we've been sharing ideas, developing clinical initiatives, and trying to publish in this area, which has not always been easy, I have to say. And there's a lot of trainees and students who come on placements with us, who are very enthusiastic as well, for various reasons. I think everyone knows somebody who's had a head injury. And they're now assuming that actually incorporating the family is the way to do things. So this is my professional network webpage. As I say, professional network. We have one or two other people on the network who I think use it for to be aware of what we're discussing. And some of the clinical papers and ideas we've developed in terms of engaging with families is to think about, if you like, there's a lot of talk in therapy circles about the Therapeutic Alliance, and we've tried to think about how that would apply to neuro-rehab, and to try and understand where sometimes there's a mismatch between people's high or low expectations. How does that arise? And my colleague Siobhan Palmer developed this tentative model for trying to understand how we engage with families, and suggests that we share the power, we involve them, we show empathy, respect, understanding. We try and offer information, time and flexibility, and be honest about our limitations. If we as professionals don't do that, then we do people a disservice. I myself focused more closely on progressive conditions in one particular paper, and coined the term relative care pathway. What do relatives need? They need a plan for the next care stage. If it is a progressive condition, what's going to happen next? How is the family going to cope with that? What should we be expecting? Let's actually broach, have that conversation with families about the word carer. Who considers themselves a carer? Is it useful? Is it useful? I definitely try and dissuade people from using, having a main carer, if you like. I don't think that is a helpful term. And to help the family think around issues of boundaries, age-appropriate areas of responsibility. Particularly important if there's siblings involved. Have a plan for what happens if paid or unpaid carers are ill or absent for whatever reason. Be clear with families that their role is to have quality time and do fun activities, not personal care tasks. Or not always. If the family member with MS, this was the focus of this particular paper, has children, encourage the other parent to speak directly to the children and contact the school. And encourage family members to access their own personal support. Giles Yeates has looked at applications of narrative therapy to brain injury, and in his paper he talks about brain injury as a thief, an intruder, an unwanted guest. This is what he understands from talking to lots and lots of relatives of people with brain injuries, that brain injury has a certain characteristic, that it's like a force that separates people and exists in spaces between people. Narrative therapy really finds it's very helpful to, if you like, name the injury and give it, let's look at what kind of character it has. It's a way of just putting the injury a little bit out there rather than in here, and helps the family discuss it and unite against it. So for some time now we've been widening, if you like, the practice to include family members, and we may have an equal number of consultations with family members there as with the individual. We try and come to some shared understanding of what a brain injury is and looks like and behaves, and we pay special attention to exceptions to the rule and individual differences. So therapy often sometimes therapy needs to focus on circumstances when the injury can be overcome when it's not there. And that usually is with the support of a family member. So the rationale really is that if we can promote healthy family functioning, we actually maximise the chances of rehabilitation working, and that is coming out of the literature now. That is what we're finding in the research, as well as what we've kind of known clinically for a long time.